Hello, my name is Dr. Hannah Rosa. I'm a GP working in the northeast of England, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts. Please follow us to receive notifications about new episodes. And if you like what you hear, please consider leaving a review to help other listeners find us. You can also follow us on X at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. In this episode, we will be discussing acne. To introduce this topic, I thought I'd start with a case. Leanne is 17 years old. She is studying for her A-levels and hopes to study psychology when she leaves school. She has come to see you today as her acne is starting to affect her confidence. She has tried a wide variety of over-the-counter treatments, but hasn't found anything that's really helped. This is a typical GP presentation, and we will follow Leanne's care as we progress through this episode. In this podcast, we are going to cover acne in 4 steps. First, we will focus on the diagnosis of acne, including how to grade its severity. Second, we are going to look at what constitutes good general skincare advice. Thirdly, we're going to look at management. And then finally, we will focus on the new MHRA guideline on isotretinoin. We will then finish with a quick quiz so that you can test your knowledge. Step 1 then, diagnosis. NICE states that comedones must be present for a diagnosis of acne to be made. Comedones are non-inflammatory lesions which may be open, blackheads, or closed, whiteheads. Inflammatory lesions may also be present, and these include papules and pustules, which are less than 5 mm in diameter, and nodules or cysts, which are larger than 5 mm and often painful. When diagnosing acne, it's important to convey to patients that it is incredibly common. About 95% of people aged 11 to 30 are affected by acne to some extent. It is usually linked to changes in hormone levels during puberty, but it can start at any age. It is not caused by being unclean or eating the wrong foods, but some medications can cause acneiform eruptions, including steroids, some anti-seizure medications, and progestogen-only contraceptives. Hyperandrogenism can also be a possible underlying cause, and may present with irregular periods, androgenic alopecia, or hirsutism in women. Other conditions which can also cause papules include rosacea and periorificial dermatitis. Rosacea typically starts with redness, and then sometimes papules or pustules can develop. Periorificial dermatitis causes clusters of papules to erupt around the eyes, nostrils, mouth, and occasionally the genitals. In both conditions, you don't get comedones, and the skin tends to feel dry, whereas in acne it can feel greasy. When it comes to grading the severity, NICE classes acne as either being mild to moderate or moderate to severe. For mild to moderate acne, you can have any number of blackheads or whiteheads, up to 34 papules or pustules, and up to 2 nodules. For moderate to severe acne, you need to have either 35 or more papules or pustules, or 3 or more nodules. Now, I appreciate that this potentially requires a fair amount of counting. Acne can become even more severe, but thankfully this is rare. A more severe form is nodular cystic acne. This is characterised by nodules and cysts that typically resolve with scarring, and is associated with hidradenitis suppurativa. A severe form of nodular cystic acne is acne conjugata, where interconnecting sinuses and abscesses form. These severe types of acne both require a referral to dermatology. And finally, a more severe form of acne conjunctiva is acne fulminans, which is where systemic symptoms such as a fever, arthralgia and malaise develop. This requires urgent referral to the on-call hospital dermatology team to be assessed within 24 hours. First-line treatment is usually oral steroids, followed by the introduction of low-dose oral isotretinoin. We should also consider referring to dermatology patients who have acne with scarring, with persistent pigmentary changes, or if their acne is affecting their mental health. Coming back to Leanne, on examining her skin, you can see that she has a large number of comedones, especially around her forehead, nose and chin, and a few on her back. She also has 10 pustules, 5 bigger nodules, but thankfully no scars. Having this many nodules puts her into the moderate to severe category for her acne. She has no other features of polycystic ovarian syndrome, such as excessive face or body hair, and her periods are regular. Her BMI is 20 and her blood pressure is normal. Following the NICE guidance, what would you advise Leanne in terms of general skincare advice? And which treatment options would you offer? So, step 2. What constitutes good skincare? First, I let patients know that they should resist picking or scratching their acne, as it can increase the risk of scarring. They should also look after their skin by using a non-comedogenic sunscreen in good weather, not only to protect their skin from sun damage, but also because UV radiation can make acne worse. NICE don't recommend following any specific diet to help to treat acne, other than following a healthy, balanced diet. When it comes to cleansing the skin, people should use a non-alkaline synthetic detergent cleansing product, or Syndet, twice a day. The skin itself has a slightly acidic pH, whereas traditional soap is alkaline and can potentially have a negative impact on the skin. There are a wide variety of Syndets that can be bought over the counter. 5% benzyl peroxide wash and gel can also be bought over the counter in the UK, and NICE recommend that this can be used as monotherapy alone if other treatments are contraindicated or wish to be avoided. There are 3 key side effects to let patients know about with benzoyl peroxide. I use the not quite so catchy acronym BPI for benzyl peroxide to help me remember these 3 side effects. B is for bleaching of the hair or clothes, P is for photosensitivity, and I is for irritability. As with all topical treatments for acne, we should advise patients to build up the use slowly. For example, to start by using it on alternate days and washing it off after an hour. Step 3. Let's think about prescribed medical treatments. Following the NICE guidelines for someone like Leanne with moderate to severe acne, which options would be most suitable? Let's go through the guidance starting with the topical gels, and here it's all about using a fixed combined treatment in the evening, but remembering to advise patients to start building up the use slowly. These treatments should be used for 12 weeks, warning patients that positive effects can take 6 to 8 weeks to become noticeable. First, we have benzoyl peroxide with clindamycin gel, and NICE recommend that this is suitable for mild to moderate acne only, so not for Leanne. But it can be used during pregnancy and breastfeeding. As it contains benzoyl peroxide, remember our BPI side effects. Our next 2 topical fixed combination gels both contain a retinoid. There's adapalene with benzoyl peroxide, or Epiduo to give it its brand name, and tretinoin with clindamycin, or Treclin. These can both be used with any severity of acne, so either may be a suitable choice for Leanne. When it comes to pregnancy, the MHRA advises that systemic exposure is thought to be negligible following application of topical retinoids. However, since risk cannot be excluded, use of topical retinoids is contraindicated during pregnancy as a precaution. For this reason, the MHRA also advises that females of childbearing potential should use effective contraception. They both can be used when breastfeeding though. A few other things to note. As Epiduo doesn't contain a topical antibiotic, an oral antibiotic can be added to it for acne treatment. And Treclin is contraindicated in perioral dermatitis, if there is a personal or family history of skin cancer, and in rosacea. So far then, for Leanne with moderate to severe acne, we have 2 topical treatments which may be suitable, Epiduo or Treclin. For moderate to severe acne, NICE also recommend that we can use oral antibiotics with a topical agent first line. When it comes to antibiotics and acne, there are 3 golden rules. Do not use a topical antibiotic alone, do not use an oral antibiotic alone, and do not use a topical antibiotic and an oral antibiotic together. These rules exist to reduce the risk of bacterial resistance and to target the different pathophysiological mechanisms in acne. The topical gels which NICE specifically recommend to use with oral antibiotics are Epiduo once a day or topical azelaic acid twice a day. These can be combined with oral limacycline 408 mg or oral doxycycline 100 mg. Doxycycline may cause more photosensitivity than limacycline. For people who cannot tolerate or have contraindications to these antibiotics, we can consider using trimethoprim or an oral macrolide, for example, erythromycin. So here NICE have thrown in a different topical treatment, azelaic acid. This can come as either a cream or a gel, with the cream being preferable for people with sensitive skin and the gel for people with very oily skin. Some people may prefer azelaic acid to benzoyl peroxide as it is less likely to cause skin irritation. Now, there is another option that we can use to treat Leanne's acne. NICE advises that the combined oral contraceptive, if not contraindicated, in combination with topical agents can be considered in women. A meta-analysis of 32 randomized control trials found that although antibiotics may be superior at 3 months, combined oral contraceptive pills were equivalent to antibiotics at 6 months in reducing acne lesions. The next question then is which type of combined oral contraceptive is best for acne? A Cochrane meta-analysis examined the effectiveness of 6 different types and found that all 6 were effective in reducing inflammatory and non-inflammatory facial acne lesions, and they weren't able to recommend one type over another. The FSRH in their 2003 guideline also don't recommend one type of combined pill over another for acne. NICE states that 3rd and 4th generation combined oral contraceptives are generally preferred, such as Gederal, Mercilon, Marvelon, Yasmin or Lucette. However, the FSRH does warn that a slightly higher VTE risk has been associated with these pills, although the absolute risk of a VTE for an individual user remains very small. Combined oral contraceptives containing cosiprindiol, such as Dianet, were traditionally felt to be more effective in treating acne due to their anti-androgenic properties, and they are still listed as an option in some regional dermatology guidelines here in the UK. However, the incidence of VTE is 1.5 to 2 times higher compared with oral contraceptives containing levonorgestrel. For this reason, NICE in their acne guideline and the BNF state that cosiprindiol should only be used in people with acne related to polycystic ovarian syndrome. NICE state that these patients could use it or an alternative combined oral contraceptive pill alongside a topical agent if first-line options haven't helped, and that it should be discontinued 3 months after acne has been controlled. We should also consider referring people with acne and PCOS with additional features of hyperandrogenism to an appropriate specialist. for example, a reproductive endocrinologist. I'd just like to add here a special note for people with skin of colour who have acne. People with skin of colour are at an increased risk of post-inflammatory hyperpigmentation, and for this reason we should aim to treat and refer them early. Topical therapy with retinoids and azelaic acid can be particularly good, as these treatments can target both the acne and the post-inflammatory hyperpigmentation. However, please counsel patients to initially use these treatments less frequently, for example every second or third day, and for shorter periods of time. This is because all topical acne treatments can cause dryness and irritation, and this can then cause or worsen hyperpigmentation. So which management option did Leanne choose? Well, she opted to start on microgynon, a combined contraceptive, with adapalene and benzoyl peroxide gel. All patients with acne should be reviewed after 3 months, and when Leanne is seen again, unfortunately she hadn't noticed any difference with her skin, and she was keen to try something else. So, what would you recommend next? As her moderate to severe acne hasn't responded adequately to a first-line treatment, which didn't contain an oral antibiotic, then NICE advise offering an oral antibiotic now, alongside an appropriate topical option, such as Leanne's adapalene and benzoyl peroxide gel. If Leanne had already had 3 months of an oral antibiotic and her skin hadn't responded, then NICE recommend considering a referral to dermatology at this point to reduce the potential risk of scarring. Now this differs from the advice given to us in primary care by most regional guidelines, where they tend to recommend that we try 2 different oral antibiotics for 3 months each before we refer. If Leanne had used an oral antibiotic for 3 months and her acne had completely cleared, then we should now stop the antibiotic. Evidence suggests that there is little additional benefit in using antibiotics for more than 3 months, and in addition, prolonged use can increase the resistance of Cutibacterium acnes. However, if she had been using an oral antibiotic for 3 months and her skin had improved but the acne hadn't cleared completely, then the oral antibiotic, alongside an appropriate topical treatment, could be used for another 3 months. NICE do highlight that topical or oral antibiotics should only be used for more than 6 months in exceptional circumstances, but that courses can be repeated in the future if needed. For a patient with mild to moderate acne, if after 3 months their acne hasn't responded to the first treatment option, then we should offer them a different combination topical treatment. NICE then advises that if after 6 months of trying 2 different topical treatments their acne still hasn't improved, then we should consider a referral to dermatology. Again, this differs from most regional guidelines, where trialling an oral antibiotic at this stage is usually recommended. So Leanne chooses to stay on her combined pill and her adapalene and benzoyl peroxide gel, and she starts on limacycline. You see her again 3 months later, and concerned about the risk of scarring, you agree, following the NICE guidelines, to refer her to dermatology for consideration of oral isotretinoin or Roaccutane treatment, as her acne has still not responded. This leads us on to step 4. Isotretinoin is a vitamin A derivative that is highly effective as an anti-acne therapy. It can be considered for people older than 12 years with a severe form of acne that is resistant to adequate courses of standard therapy with systemic antibiotics and topical therapy. It can be prescribed only by a consultant dermatologist-led team. At this point, other than writing a referral letter containing all the treatments that Leanne has already tried, would you do anything else in preparation for Leanne potentially starting isotretinoin treatment? Well, NICE recommend that we should also provide details of the patient's current and previous mental health history, and fully inform the patient and their family and carers as appropriate of the potential risks and benefits of the treatment. The MHRA recommend using the British Association of Dermatologists isotretinoin leaflet. This leaflet highlights the potential mental health side effects: depression, anxiety, psychotic symptoms, and very rarely suicidal thoughts, suicide attempts, and suicide have been reported. Therefore, if a patient could benefit from support with their mental health, then they should be referred for therapy before starting isotretinoin treatment. It is also worth remembering here that helping a patient with their acne can improve their mental health. A study from 2022 showed that compared with antibiotic treatment, isotretinoin conferred a lower risk of 6 psychiatric comorbidities and comparable risk of suicide attempts. The leaflet also has a section on side effects affecting sexual health. These are rare but can include experiencing low libido, vaginal dryness, difficulty getting or maintaining an erection, and reduced sensation in the genitals. The other big side effect to inform women of childbearing potential is that isotretinoin is a powerful teratogen, as it has been associated with a high frequency of severe and life-threatening birth defects. For this reason, these women must agree to use at least one very reliable method of contraception, for example, an intrauterine device or contraceptive implant, or 2 effective methods that work in different ways, for example, a hormonal contraceptive pill and a condom. And this again is something that we are encouraged to speak to women about when we are considering referring them. Some regional guidelines ask primary care to check some blood tests when referring patients, such as USNEs, LFTs, TFTs, and lipids. The final thing that NICE asks us to do when making a referral for possible isotretinoin treatment for a patient who is under 18 is to document whether we are willing to become the second approved named healthcare professional who agrees that isotretinoin is an appropriate treatment. In 2023, the MHRA introduced a new safety measure, stating that 2 independent prescribers need to agree to the initiation of isotretinoin in patients under 18 years. The second approved named healthcare professional can be the primary care clinician making the referral to the specialist. This may be a GP, advanced nurse practitioner, advanced clinical practitioner, or future equivalents. Once a person's acne has responded well, they may require maintenance treatment. This is not always necessary, but should be considered especially in people with a history of frequent relapses after treatment. Topical treatments which don't contain antibiotics can be used, such as the combination gel Epiduo or monotherapy with either a topical retinoid, benzoyl peroxide, or azelaic acid. Females are more likely than males to have acne into adulthood, and adult female acne may persist until the postmenopausal period. This group can suffer from frequent relapses and again may benefit from topical maintenance therapy. Azelaic acid or the retinoid adapalene are recommended here. So back to Leanne. She had a 6-month course of isotretinoin. She experienced mild side effects only, and 2 years later, her skin is still clear from acne. This brings us to the end of our case. For further information and for patient information leaflets, I'd recommend the British Association of Dermatologists, or BAD, website. And for even more detail on acne, they have also created the Acne Support website, which again can be a good resource to direct patients to. Now, as promised, a chance to test your knowledge with a quick quiz. Feel free to pause the podcast after each question. Question 1. According to the NICE guidelines, to have moderate to severe acne, a person needs to have 35 or more inflammatory lesions, or at least how many nodules? The answer is 3 or more. Question 2. In which type of acne can you get systemic symptoms, which requires urgent referral on the same day to dermatology? The answer is acne fulminans. Question 3. What are the 3 main side effects of benzoyl peroxide gel? The answer is bleaching of the hair and clothes, photosensitivity, and skin irritation. Question 4. A combination gel containing benzoyl peroxide and topical clindamycin is suitable for mild to moderate acne only. True or false? The answer is true. Question 5. Name 2 topical treatments which can both help to treat acne and post-inflammatory hyperpigmentation. The answer is topical retinoids and azelaic acid. And lastly, question 6. Before referring a patient for potential isotretinoin treatment, as well as writing a letter containing all the treatments that the patient has tried so far, name 3 other things that we could do. For your answer, you could have had that we should give the patient information about the potential benefits and risks of isotretinoin, including by providing them with an information leaflet. Consider the person's psychological well-being and consider if a referral into mental health services is appropriate. Discuss contraception with women of childbearing potential. Check blood tests if required in your area. Or if the patient is under 18, document if you are willing to be the second approved named healthcare professional. How did you do? Thank you all for listening. I hope that you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts to help improve the lives of our patients in primary care. Right, I'm off to replace all the soaps in our house with Sindets. Goodbye.